For the last session of this beautiful day, the speakers are going to talk about prognostic factor on therapeutic strategy. For the first presentation, I call Professor Marc Tintoré from Barcelona and Professor Emmanuelle Leray from Rennes.
So, dear Professor Edan, dear colleagues, it's my great pleasure to introduce Dr. Marc Tintoré from Barcelona, Spain. I have the slides. So, from Spain. So, as all of you know, she's a neurologist, and she's head of the neurology department of the University Hospital of Barcelona. She has been involved in MS research for almost 25 years, as highlighted by her high number of publications you can find on PubMed website. And it's incredibly fairly constant every year, so I think it's a model for all of us. Our main research focus is about prognostic factors in MS. And in Barcelona, they had the opportunity to collect prospective data from a big cohort of CIS with a total number of approximately 2,000 cases now. And most of our work led to a better knowledge of what are prognostic factors for MS, prognostic factor for disability progression, but also for disease course, and especially the central, the main prognostic value from baseline MRI, and this figure has been already previously shown by David Miller in the afternoon. All of this work also was very helpful for researchers, clinicians, and epidemiologists because they tried to propose a classification of prognostic factor of the disease, and especially they tried to classify it into low prognostic value or medium or high prognostic value. And I will now let her go in deeper detail of this exciting topic. So please.
So, good afternoon. Let me start by thank you, Emmanuelle, for her kind presentation, and also Gilles for inviting me to be part of this very distinguished panel. I am very impressed. I also had the opportunity to work and to meet Gilles many years ago. We had some common interest, and we were at that time working, for example, in the design of a trial comparing oral versus IV methylprednisolone. So I had the opportunity to come here and to discuss the COPUSEP, who was also led by Emmanuelle Lepage, and who was very brilliantly published in Lancet very recently. And I also would like to highlight the importance of this group in the concept of induction therapy, because I think they were one of the first to really discuss this importance, and we more and more are going to this strategy. And these are my disclosures. So we are fortunate, and we have seen this slide several times, to have a great number of drugs that are available. And of course, randomized trials, they only give us a small window of what is happening from the drugs. But we need also real-world studies to see how to choose and how to monitor, and how what we see on the clinic or on the MRI is going to impact in the future. And one of the things that we have learned from these 25 years is that time is also brain in MS, as it is, for example, in stroke. And for the strategy that we were using usually, that is going through one step to the other and to the high efficacy drugs at the end, but we have also learned that there are patients that need clearly a shortcut and that they need to start by this induction therapy. And I think the Rennes group has deeply contributed to this concept. And how do we monitor our drugs? It is important to do so, and we have the majority of data on what we call the platform therapies, which are the injectables. And what we did usually several years ago when we start with this drug is to monitor them clinically. That means that when we started the treatment, we were counting whether the patient was presenting with relapses or disability increase. And we have now long-term data of patients treated with platform therapies and followed with this strategy. These are data coming from our group, but there are other data also similar from clinical trials that have been extended for many years, and they show that the presence of clinical activity when the patients are on treatment is associated clearly with a higher risk of having a secondary progressive MS or, for example, an increase of 5 EDSS steps, so very hard endpoints. And also patients having relapses while on treatment, this was also associated with a bad outcome in the long term. But with the time, we've been able to incorporate MRI into our monitoring, and we are able to incorporate these 3 measures when we are controlling our platform therapies. And this is also coming from our group, and in this study, there's an 8-year follow-up, and looking during the first year of therapy for the presence of relapses, EDSS progression, or MRI activity, and patients are then followed for 8 years and looking at the outcome as having an increase of at least 2 EDSS steps, so also a hard endpoint. And here we apply the RIO score, in which you have to have clinical and MRI activity. And it was clear that those patients that during the first year, they fulfill the RIO score, this is associated with clearly an increased risk of having an increase of disability after 8 years of follow-up. You know that there has been also some modification to the RIO score in which the relapses have been divided into different number of relapses, and the threshold for active lesions have also been changed. And in our cohort, however, the modified RIO score was not clearly associated with this increase in the EDSS in the long-term follow-up. But of course, we have more and more new drugs that are coming with a higher efficacy. And we have heard very clearly about the concept of NIDA, no evidence of disease activity. This is a concept that is coming from rheumatology, but is clearly taking an important place in our practice. And I'm not going to insist on what the NIDA-3 is, but we have seen that NIDA is used in clinical trials more and more, but clearly NIDA is also being used in our clinical practice. These are data coming from the CLIM cohort, and the patients follow for 7 years treated with platform therapies. And the important message here is that if you are NIDA after 2 years of therapy, in this study, this was associated with good prognostic implications, because you have almost an 80% possibilities of no changing your EDSS over the next 7 years. But the second important message is that with platform therapies, only a small proportion of patients here in this study, only 8% of the patients maintain this NIDA status. So really a very small proportion. This is another study coming from the Italian group, and here the message was that in this group of patients also treated with first-line drugs, at 10 years, only 9%. So really this is a very demanding concept and difficult to be sustained with first-line drugs. In this study coming from the Czech Republic, even 0% of the patients after 10 years were NIDA in the relapsing remitting disease patients. And here also to be NIDA had also prognostic implications. However, NIDA, and we have heard also, is depicting only the focal part of what is happening in this disease. And therefore, there are new concepts that have been incorporated or that want to be incorporated. And probably the most important one is brain volume loss, because it's going to tell us more about the diffuse disease activity of this disease. And this is a study we performed in Barcelona, also in patients treated with platform therapies. And we looked at atrophy during the first year of treatment. And it was shown that those patients that had more atrophy during the first year of treatment, this was associated with an increase in disability, but in the long term. So there is a gap between what we see in disability, in atrophy in the MRI, and the impact we are going to see in the clinic. In this study, there was a gap of almost 4 years. And we have also heard from Professor Capos about this threshold that seems to be 0.4, who seems to be the threshold who better differentiates MS patients to healthy controls. So we are moving to this NIDA-4 concept. However, there are other needs also that are not probably depicted by atrophy, and cognition many times is not depicted, but this NIDA-4, and also patient-related outcomes such as fatigue, depression, anxiety, or quality of life. This is a recent study in which patients that were NIDA, half of them, if you study them from the cognitive point of view, half of them, they had worsening in their cognitive domains, showing that even if you are NIDA, there have other aspects of the disease who might be changing. And we are going to hear more after my talk on how biomarkers can help us also in relation to this topic. And there is this combined assessment that probably is the future, in which probably we need to combine to the NIDA assessment all these aspects that I have highlighted. However, in clinical practice, this is not that easy. We know that the drugs may take some time to start working, and many authors are now considering the need to rebaseline our patients. And also, when we are dealing with new T2, there is a variability when we are counting lesions. So this is not that straightforward. And also, although we have strict guidelines on how MRI protocols should be performed in clinical practice, we all know that this is not always possible in our routines, and that many times we do not fulfill these strict clinical MRI guidelines. So probably because there is this variability, at least in our patients also treated with platform therapies, it was clear that, for example, the occurrence of just one new T2 or two new T2s was not associated with long-term prognosis. However, if you then increase your threshold to 3 new T2 or to at least 2 gadolinium-enhancing lesions, this was associated to an increase of at least 2 EDSS steps on the long term. Similar to our results, this study coming from the Magnim's group, in which there was a large number of patients that were treated with interferons, also show that the presence of a small amount of MRI activity, less than 3, this was not associated with a bad outcome in the long term, and this was developed in the Magnim's scored development. And it is also important, and we have also seen data this morning regarding the importance not only of new lesions number, but Professor Miller also showed information on the importance of topography of the lesions regarding prognosis. And this has also been shown in terms of monitoring treatment effect, where the presence of infradentorial or spinal cord lesions was associated with EDSS progression in the long-term follow-up of these patients. What about monitoring patients with glatiramer acetate? There are less studies, but also the presence of clinical and MRI activity was associated with long-term disease progression. What do we know about monitoring orals? There is less information, but there are also data coming from the fingolimod trials in which patients were controlled for the first year, and it was shown that those patients that present relapses during the first year of therapy, this is associated with an increased risk of future relapses or disability progression. But also the presence of MRI activity, also a certain amount of MRI activity was associated with disability or with relapses in the follow-up, and also, of course, the combination of the two. So pretty similar to what we have seen with platform therapies. Also, this other study in patients treated with fingolimod, and also looking at the risk of being disability increase over 4 years, it was shown that the presence of relapses during the first 12 months is associated with this increased risk of disability progression. If we look to MRI outcomes, here it was also shown that the presence of atrophy, here defined with a larger cutoff of 0.8%, this was also associated with this risk of disability progression, and also the presence of persistent new lesions, which means lesions both during the first 6 months of treatment and persisting also new lesions from month 6 to month 12. This was also associated with this increased risk. We have also few data regarding what happens in patients treated with teriflunomide, and also the response to treatment seems to be pretty similar, showing that those patients that have clinical and MRI activity, or at least a certain amount of MRI activity, they are also at risk of having disability increase in the long term. But what happens with monoclonal antibodies? And here I would like to show to you one of our cases. This is a patient that we saw in our unit that was treated with glatiramer acetate, and the patient was still very active, and for this reason the patient was changed to natalizumab. After 1 year of natalizumab, we performed an MRI, and there were still 6 new lesions. So at this time, and looking at what we usually have learned from what happens in platform diseases or in oral treated patients, one may think that probably we could switch to another therapy or to maintain the therapy. In fact, if we look at our cohort of patients treated with natalizumab, at least 1/3 had a relapse during the first year, and at least half of them had new T2 during the first year. So what we did in this patient was to maintain the treatment, and after 2 years, there were no new lesions. So, and also, this is also shown in this figure, where after the second year, the number of new TT lesions clearly decreases. And probably this is highlighting that during the first year, many times, what we are seeing is this carryover activity. What it is clear is that when we use these monoclonal antibodies, the number of patients reaching NIDA is clearly different from what we have seen with platform therapies. And also, if we look to NIDA at the long term, we remember that, for example, in platform therapies, the percentage of patients having NIDA in the long term was around 8%, the most optimistic. Here we have a higher proportion, almost 35% of the patients treated with natalizumab at the long term maintain this NIDA. And let me show you a second case. This was a patient that was failing to different drugs, treated with different interferons, then going to natalizumab, then having to switch to fingolimod because of JC virus positive, and the patient was still active on fingolimod. And for this reason, we decided to move the patient to alemtuzumab. Because of problems with vaccinations, we have to wait a little bit, and the patient was then very active before starting alemtuzumab. And then the patient received this first cycle, and after 12 months, in fact, there were 6 new lesions for gadolinium positive. There was a debate whether to maintain the treatment or no. Finally, the treatment was maintained, and after 2 years, there were no new lesions. However, I could also show you a similar patient in which the second cycle, the patient was still very active. We have also learned that with certain drugs, such as alemtuzumab, this drug has a long-lasting effect. And also, as we have seen with natalizumab, the percentage of patients maintaining NIDA is clearly different to what we have seen for patients with first-line drugs. And these are only 2 examples. And we do not have so many data on ocrelizumab, but this is also an important drug that is going to play a key role in the future years in our daily practice, in which, again, we see that the proportion of patients reaching NIDA is clearly a different proportion. I have put cladribine in a different section from the other orals, and just to mention that this is also a drug that probably has a different category of efficacy and is going to also bring us very good data on NIDA. Probably, however, the procedure that is associated with a higher NIDA is autologous hematopoietic stem cell transplantation, who reaches percentages of NIDA of around 70% in 5 years. And what about the assessment of patients with progression? We have also heard about this possible measurement, which is called the NIPAT, which could identify those patients that are having no relapses, no progression in walking, but no progression also in their arms, and also no brain MRI activity. And we have seen that, for example, for progressive patients, this is an outcome that may be very informative. So I think I have to summarize what we have learned. I think we have learned that it is important to treat early and to monitor closely. Probably clinical or MRI activity after 1 year of injectables or classical oral treatments may predict relapses and disability progression. And probably a MEDA is more realistic when dealing with these injectables or orals. But clinical or MRI activity after 1 year of these monoclonal antibodies, of these highly efficacy drugs, may probably represent a carryover activity. And the definition of treatment failure in this highly efficacy drug is not established. When do we have to define that these drugs have failed? The 2 cases I have shown you, the patients had no more activity after the 2nd year, but this is not always the case. And it is difficult to identify those patients that are going to be true failures. And I think we need much more studies in this to identify what is treatment failure in these high-efficacy drugs. NIDA-3 can be achieved and maintained successfully over time with these high-efficacy drugs, and probably NIDA-4 or other combined NIDA are still difficult to be implemented in clinical practice, but clearly we need to go to this in the future. And I would like to close by thanking again Gilles for this wonderful day, and I'm very glad to be part of this panel. Thank you very much, Gilles.
Thank you very much. I invite the next speaker, Per Sorensen from Copenhagen, to join us with Professor Oger from Vancouver, who will introduce him.
Could I have the first slide, please? Here, I'm very honored to introduce you to a French audience. I will do it in English because this is the language that we have. I'm sorry, I don't speak a word of Danish. I have tried to spell your name as I see it spelled. And Dr. Sorensen, Professor Sorensen has been very active in multiple sclerosis in the tradition of the Nordic countries, and specifically Danish tradition. You should know that the Danish neurology has always taken patients coming from great distances, from Greenland, which is half shared with Canada, or maybe from Iceland and the Faroe Islands. They were all seen in Denmark. Evidently, he's a medical doctor, neurologist. I don't know why I put this. He has been the president of the Société Danoise de Neurologie, au comité directeur de la Fondation Charcot, à l'extrême. Il a eu une grande carrière. Il est maintenant membre honoraire Il a été advisory à la MS Society des États-Unis. Il est sur le board le Medical Advisory Board of the IFMS, membre du comité scientifique de la Progressive MS Alliance, executive member of European Academy of Neurology, membre d'honneur de la Société Française de Neurologie. Ça, c'est juste pour montrer qu'il a fait partie de nombreux comités sur les clinical trials and also the data monitoring boards. Je parle français, anglais, breton un peu, mais bon. Et 389 publications indexées à PubMed, mais surtout pour la sclérose en plaques, la neuro-oncologie et les cérébrovasculaires diseases. Mais regardons ces publications de plus près. C'est très intéressant. En fait, Pear has always been trying to look for markers. If you look at some of his first publication, we all know that propranolol does something on tremor, but very few people have measured the level of propranolol in the blood. Il a fait ensuite une série d'études très intéressantes sur la pathophysiologie de l'hypertension intracrânienne, avec mesure de la vasopressine du LCR. Ces études se sont étendues même à la syphilis, puis à l'effet des électrochocs. Sur ces premiers 30 publications, only one is devoted to MS. But after a small detour to vascular, then he started to organize, coordinate, publish on MS therapies trials. Le centre d'études de la SEP à Copenhagen has become one of the great centers of epidemiology of the disease. Il a reçu de nombreux awards, mais la seule sur laquelle je voudrais me porter aujourd'hui, c'est celle de la Charcot qu'il a reçue à l'ECTRIMS. Et je reprends à mon compte les paroles que Reinhard Horfeld a prononcées en remettant le prix Charcot à Père Sorensen. J'admire Père comme un vieil ami, collègue et père, mais aussi pour les contributions majeures qu'il a apportées à la SEP, spécialement en ce qui concerne le traitement. Père fait partie d'un petit groupe de pionniers qui ont indiqué l'importance de la collaboration entre les experts européens et qui a développé l'ECTRIMS comme on la voit aujourd'hui. C'est le mérite superbe de Père d'avoir créé la coopération internationale et c'est ce qui lui donne le droit de figurer parmi le petit groupe des pionniers qui ont créé cette collaboration entre experts européens. Je vous donne Père.
Thank you, Oger, for this kind introduction, and thank you to Gilles for including me in the faculty of this important day. I would like to, you have asked me to talk about biological biomarkers and how they have impacted our treatment monitoring. And just to recapitulate what we mean by a biomarker, it's a characteristic that is objectively measured and evaluated as an indicator of a normal biological process, a pathogenic process, or a pharmacological response to a therapeutic intervention. And we sometimes distinguish biomarkers into type 0, which is biomarkers that deals with the natural history and prognostic factors, and type 1 biomarkers that measures the effect of treatment. And as you know, what we really want to be able to is to use biomarkers in personalized medicine, so that we use biomarkers in the blood, the cellular profile, RNA, proteins, metabolomics, and others, and in the CSF, to make a rational choice of the therapy that should give the patients the best optimal therapy, and also use the biomarkers to monitor whether treatment is effective. And of course, we know that if we look at the different compartments, CSF is definitely the compartment that is closest to the pathological process, but outside Scandinavia, it is difficult to make repetitive lumbar punctures during 1 or 2 years. So therefore, of course, we still have the oligoclonal bands that has been used for diagnostic for many decades, and also has a prognostic importance in patients with CIS. I will talk a little about neurofilament also, and then in the CSF, because this has been studied for many years, and then for biomarkers in blood, we have for use that have gained use in daily clinical practice, in neutralizing antibodies against interferon and natalizumab, JC virus as a measure of the risk of PML in patients treated with natalizumab, varicella zoster antibodies, and again neurofilament. But for many of those, the new markers, we have to remember that these have been shown to work on a group basis, and we need to see if this can be transferred into use in individuals in daily clinical practice. As you know, most biopharmaceuticals induce antibodies, and different reasons for that. And those that have been measured and used in clinical practice are the antibodies against interferon beta and against natalizumab. Well, if you develop antibodies against interferon beta, these antibodies may interfere with the binding of the molecule to the receptor and with the signaling further into the interferon response element. And there have been several methods for measuring antibodies. The cytopathic assay was the first one. The MXA assay has been used, and now the luciferase assay is probably the most commonly used. And in fact, if we look at the literature of treatment with interferons, so you can see in all these trials, whether it's been phase 3 trials or other trials, observational trials, neutralizing antibodies have been discovered in all trials, but in very varying frequencies, from a few percent up to more than 40%. So when interferon was introduced first, it was very clear that in the beta-ferron trial, if you developed antibodies, you significantly increased the annualized relapse rate to the level of the placebo-treated patients. And also, if you looked at interferon beta-1a, there was a clear effect of interferons. And you could say, well, this everybody should agree on that. But in the following years, there were more and more publications doubting the negative effect of antibodies. And the reason for that is that it is not an either-or. Neutralizing antibodies in low concentrations do very little to the disease activity, whereas in high concentrations, they abolish the therapeutic effect. And if you only say if there are antibodies or not, this will cause many problems. Another thing is that the dynamics of antibodies is important. It takes some time before antibodies develop, usually between 9 and 18 months. And the vast majority of patients who develop antibodies have developed antibodies before 2 years of therapy. But the other thing is that even when we have a continuous treatment with interferons, many patients who are antibody negative revert to the revert to the antibody negative state. In fact, after 3 years treatment with beta-ferrin, more than half of the patients have reverted to the antibody negative state. And then again, if we look what happens when we discontinue interferon beta therapy, the titers of antibodies may be high for more than 3 years. So if we don't take this into consideration, it is very difficult to understand how you should measure and evaluate the effect of neutralizing antibodies. So if we look at the effect of antibodies from treatment initiation and during continuous therapy with interferon beta, we can see that it takes some months before antibodies are triggered. And then interestingly, the first antibodies that we see are low affinity antibodies that in fact works as a chaperone of the molecule. They prevent the molecule from being degraded, and thereby it enhances the bioavailability of interferon. And this can be shown that in those patients who become antibody positive, during the first 12 months of therapy, they have a lower annual relapse rate in those who are maintained antibody negative. But then after some time, high affinity antibodies develop, and now you can measure a decrease in the bioactivity of interferon. And after approximately 12 to 18 months, it becomes evident that there is an effect on MRI and relapses. And with continuous long-term observations, there has even been shown an effect on progression. But again, antibodies may disappear after 18 to 36 months, even when treatment with interferon has been continued. Nevertheless, despite all these problems, we were able to show that in the whole Danish population of patients who had antibodies measured all from the start of treatment, during antibody-positive periods, there was an increase of more than 50% of the annual relapse rate compared to antibody-negative periods. And there was an increase in the time to the first relapse in antibody-negative compared to antibody-positive, and also we showed a trend towards an effect on progression. Then it was argued how there might be, even if you have antibodies, and even if you use an interferon-inducible molecule like MXA molecule, even if this is not induced, there could be other molecules that that would still be effective. And as we know, there are so many genes that are influenced by an interferon beta injection. But what we could show was, in fact, that if we could show about more than 5,000 detectable genes in at least one patient in our study. And if we looked at the patients who are antibody negative, there was still 1,000 genes that were inducible compared to 0 in antibody-positive patients without an MXA response. And this was then translated also when we looked at the response of 4 interferon beta inducible molecules, that you could see that in antibody positive patients, there was no induction after the interferon beta injection at all. And this translated into treatment guidelines in Europe recommending that, and I can see Giancarlo has arrived, so I don't need to prolong my talk, that measurements of neutralizing antibodies should be performed in all patients during treatment with interferon, that also in patients with a sustained high antibody titer, treatment should be discontinued and switched to another therapy. One of the main reasons why it has been so difficult to agree about the effect of therapy is that when you are looking into subgroups, you lose power. So, for example, if you have a power of 80% in your original trials, then if you then compare antibody positive and negative patients, the power drops to 44%. So in 2010, there was an agreement, a recommendation how we should use antibody measurements in patients treated with interference. So in patients who are antibody negative, you do nothing. You continue, and then you repeat measurements. And in antibody, in all patients who are doing poorly, you switch therapy independently of the antibody status. And also in patients with a high titer, if this is repeated, you would switch treatment, because even if the patient is doing well regarding relapses, this patient has no bioactivity of the therapy. And then the middle group with low titers, you need to measure the bioactivity using a test with an interferon-inducible molecule, that's the MXA. And this is how we also do it today. But it's interesting, and this is another thing that has caused confusion, that antibodies only explain a very small part of those patients who do not have an optimal response. And you can't deduct that in patients who are antibody negative, they would have a good response to interferon. So when we started treatment with natalizumab, it was already shown that approximately 6% of the patients developed persistent positive antibodies, and it was obvious that in patients who had consistent antibodies, there was no treatment effect left, and there's been no discussion that these patients should be discontinued and treated with another drug. Very few countries measure antibodies against natalizumab. Routinely, it is mostly recommended if patients have infusion reactions, because this is associated with a high proportion of patients who are antibody positive. What about the other monoclonal antibodies? Well, in the rituximab trial, there was approximately 25% were tested positive for human anti-chimeric antibodies, but there was no association between the antibody positivity and the therapeutic response. And with ocrelizumab, very few patients have developed antibodies in the two OPERA trials. And also in alemtuzumab, despite that the majority of patients develop antibodies, these antibodies are relatively short-lived and tend to have disappeared before the next treatment, and therefore there was no effect on sustained progression or the relapse rate in patients who developed antibodies with alemtuzumab. Another measure of antibodies in the blood is the antibodies against JC virus that have been used for risk stratification for PML. And originally we had only positive or negative, but now we use the titer, the index of the antibodies, and it is obvious that with increasing concentration of antibodies, the risk of PML is increased. So we routinely test for antibodies in patients treated with natalizumab, and if patients are becoming antibody positive, we would recommend to talk with the patients about switching to other. And in fact, in Denmark, we do not start treatment in patients who have high titers of JC antibodies. If they develop titers, of course, you have the discussion with the patients whether or not they want to continue despite the increased risk of PML. 5 years ago, I was going to give a talk about biomarkers, and I didn't know what to do, so I sent a questionnaire out to 163 well-known neurologists all over the world, and approximately half of them responded. And if you look at the response of if there were biomarkers that indicated the conversion from CIS to clinical definite MS, the majority, or not the majority, but a large proportion claimed that oligoclonal bands were prognostic for the conversion to clinical definite MS. Whereas if we look at the disease activity or disease progression, again, there was a number of the neurologists that mentioned neurofilaments primarily in the CSF, very few at that time in the blood, and in fact, those they could see what would happen in the future. But of course, the use of neurofilament is not new. It goes back to 1989, where the Gothenburg group showed that the concentration of neurofilament light in the CSF were depending on the time from a relapse to the lumbar puncture. And there was a nice decrease in the concentration the longer time elapsed from the relapse to the lumbar puncture. And then, of course, it was also a very important observation when the same group showed that in patients treated with natalizumab, there was a clear decrease in the concentration of neurofilament light in the CSF, and it was more obvious for patients with relapsing remitting MS compared to patients with secondary progressive MS. And in patients with relapsing remitting MS, it seems that the neurofilaments decreased almost to the level seen in healthy controls. And also it was shown that CSF neurofilament was associated with a more severe development of multiple sclerosis using the multiple sclerosis severity scale, and also the conversion to secondary progressive MS were higher in patients with a high concentration of neurofilament. But it was when it was shown by Jens Kuhler and others that in fact using the more sensitive single molecule array technique in the blood, there was a very strong correlation between the neurofilament concentration in the CSF and in the blood, both in HIV patients and also in MS patients. And it was also shown that there was an association between the concentration in the blood and the T2 lesion load, and also on the number of gadolinium-enhancing lesions in the brain. And even if we combine the brain and spinal cord, still there was this association between the concentration of neurofilament in the blood and the number of gadolinium-enhancing lesions. And very recently, a longitudinal study was published also from a Swedish group in Gothenburg, where they showed that when you initiate treatment, you have a decrease in the serum neurofilament light. And in those patients where you escalate therapy, there is a further decrease in the neurofilament. Whereas in patients where you have a horizontal switch to another treatment with the same efficacy, there was seen no difference in the neurofilament light. And again, in those patients with an escalated therapy, they are close to the level seen in healthy controls. And again, they could also show this very nice correlation between the neurofilament light in CSF and in the blood. So to summarize, we have some established biomarkers that have been used in daily clinical practice. Neutralizing antibodies against interferon has been widely used in Europe. Also, the measurement of the interferon-inducible genes has been used in some academic centers. Oligoclonal bands, of course, predict conversion, and JC virus antibodies are used for PML assessment. And interestingly, now we might be at the place where we are now trying to use the first biomarker for disease activity and progression, neurofilament light in the blood. And however, it probably does not distinguish between the disease activity and disease progression and atrophy. And then there is a list of biomarkers that are interesting and should be studied further for the ability to define disease activity, progression, and MS phenotypes. And I would like to end by thank you for attention, and Gilles, thank you for inviting me. And you were one of the first who outside Scandinavia who started to use neutralizing antibodies against interferon, and this was a very happy collaboration. Thank you very much.
Thank you very much, Per. The last speaker of today is Professor Giancarlo Comi from Milan. I invite him to come. And he will be introduced by Professor Jérome de Seze from Strasbourg.
Thank you. It's an honor for me to introduce the famous Giancarlo Comi. But first, I would like to thank the French Society of Neurology for this very nice meeting. I think everybody is very happy for this day. It was very interesting. And also, I would like to thank this very enthusiastic and very active president, Gilles Edan. Thank you, Gilles, for all you do for the neurology. Second, I would like to tell you my first meeting with Giancarlo. It was in 1998. It was in Istanbul. It was the ECTRIMS Congress. It was my first congress in Istanbul, and my first ECTRIMS, and I was a student. And I had to present my poster about my PhD. And some of you perhaps remember that the Congress Center was very far from the hotel. And I was very anxious, so I put my poster the evening before the day of the presentation. And at this time, you had to present the poster to a scientific committee that was directed by Giancarlo. And some posters were selected for oral presentation. And when I come back the morning of the presentation, my poster has been cancelled by the personnel of the hotel. And I had no poster. And I was on the front of my poster, and I said to Giancarlo, I'm very sorry, I'm totally disappointed, but my poster has been cancelled by the personnel of the hotel. And Giancarlo said, no panic, you will present your poster next week at the next ECTRIMS. So thank you, Giancarlo. And when I prepared this short presentation, I searched for some similarities between Giancarlo and between his institution. You all know this big house, or where the French neurology is born, and you also know the mentor of this institution. And more than 1 century ago, a man has described MS in France. So when I went to the website of the San Rafael Institute, I found some similarities between your institution and the Salpêtrière, and also some similarities between Giancarlo, who is a man who has developed MS in Italy and Europe from many, many years, I think more than 40 years. So I think you can find some similarities also between these three neurologists. And the main similarities is that Jean-Martin, Giancarlo, and Gilles is the same family, the neurologist family. Thank you.
So thank you very much, Gilles, for this invitation. I had probably the half an hour worst in my life because having canceled the flight, as you probably know, the only way to arrive here was to take a motor taxi. Don't do that. Don't do that. Because to go from Charles de Gaulle to Leys at 11 o'clock when it's so crowded, I closed the eyes for 30 minutes. I reopened when I had the possibility to say that I was still alive. I never saw something similar in my life. I thought it was only in the movies where you see this moving just from one to the other. Unbelievable, really unbelievable. So if something wrong happened in my life, never will be like this. So nevertheless, it was an experience. You know, life is made of experiences, so it's at the end I survived, so it's good. And it's really an enormous pleasure to be here with so many friends. And as you know, I used to speak French, but with the time evolution, my French has been almost completely destroyed by English. So if I try to speak French again, I will be in a very bad condition. Not that my English is not much better than that, but still I can combine together something that may help me. Gilles, you asked me just to speak about what happened in these 25 years. This is my disclosure. And first of all, of course, what happened was a very big adventure. One of the big adventures was, for sure, the European Charcot Foundation. I have first to acknowledge the important role that Otto Hommes had. Otto Hommes was the person who promoted in Europe first actins, and later he was the one who really invented the European Charcot Foundation. And really, I think that the European Charcot Foundation had in you, Gilles, really a continuous, really since the beginning support. We have celebrated just a few days ago the 25th anniversary with quite clear evidence that a lot of things happened in this period. And here you see all the meetings where you have been in this period. But two guys really have been fundamental. And I think that among so many French researchers and clinicians, I think really that everybody will agree that when you speak about MS, these two guys really had a major role, and I had the great honor to be friend of both of them and to have spent really a long part of my career sharing initiatives and activities. So really, even unfortunately, Gilles, we are a bit different now than at that time, but still not so bad, not so bad. So if I have to summarize what really happened in these 25 and more years, probably the best way is to say that we have really moved to individualized therapy. We are not really there. We are just moving the first steps. But the previous speaker, I was just able to listen to some of the peer presentation and unfortunately missed the previous presentation, but I'm sure that all the data that they provided are really, at the end, in line with this concept. And of course, a concept that has been made possible essentially for different reasons. First of all, because of the increasing knowledge at all the levels in the area of MS, but also because of the availability of great advances in the information technology that give us the power today to combine together so many data and to come up and to squeeze and then at the end to have something that we may use in the clinical practice. I will try to convince you that this is true. And the second point is that multiple sclerosis is really as I can say, the champion of the complex diseases, because it's a disease where the factors that are determining the disease and influencing the disease evolution are so variable from patient to patient. There's no one gene, no one environmental factor that is responsible for the disease. The disease in some way takes place in the body with a quite variable cocktail combination of factors. And that's probably is really one of the main reasons of the inter-individual, but also inter-individual variability. And here I try to summarize which are really the basis for individualized treatment. Just only a couple of notes about that. As I said before, is a combination of genetic and environmental factors. Some of them are well known. Most of them are really playing a very minor role in the disease, but the role is there. What really matters in terms of treatment is to try to hit the disease in the pathogenetic processes at the point where they converge. And where this convergence takes place in MS is at the level of the autoreactivity on T and B cells. So this is the point where instead to hit the individual components of the pathophysiology and pathogenesis, we have essentially concentrated our efforts in trying. And it's not really so curious that the drugs that now we will use more that are essentially immunosuppressive agents are not really new. These are our very old approach for this disease. In the late 60s, already there was some tentative to use some immunosuppressive agents. But of course, what is completely new is the way we use this drug, and that's something that I will be back in a few minutes. I don't want to spend more time about something that has been really described, but of course, to try to personalize the intervention, we need to have information about the way the disease may evolve in a person. And here is essentially a matter of natural history, prognostic factors, but also of how the natural history combine with the treatment, and how then we may try to understand which can be the treatment evolution and treatment response in the single patient. And essentially, we have heard by peers some of these factors. I don't want to repeat what has been said, but essentially they belong to these categories. I prefer just to expand a bit when this type of information is very useful. And essentially there are 3 points. The first point is, which is the very difficult one, to try to figure out which will be the response to a treatment before that we give the treatment. The second exercise is a bit more simple, is, okay, let's treat and let's try to take some, very important information coming from the way the patient is reacting to the treatment. At the end, always when you start a treatment, you do such an exercise. But here, what we are trying to emphasize is that we should try to benefit as early as possible from this exercise, not to wait 3 years, 4 years of failure before we decide to change. Here, the real point is very early trying to understand. And finally, there's some new exercise that we have to use. That is, when we start the treatment, we should also think about what may happen if I have to stop this treatment. And this is more and more relevant because of some mechanism of action. I will show a couple of examples. In terms of predicting before we start the treatment, we have already some data coming from the very early studies in CIS patients. Generally speaking, all the predictivity is much better in the early phase of the disease, and more the disease progresses, the more we lose power in predictivity. For this reason, the most informative data really coming from the CIS and early relapsing remitting studies. And in these early studies, it was quite evident that patients with a more biologically advanced disease, more T2 lesion, more brain atrophy, whatever you like, more damaging evoked potentials, they tend to respond less to treatments than those with less lesions, less MRI activity, and less clinical activity. It has been confirmed many times. We try to exercise in our center, as many other did, starting from the Barcelona center, try to combine together different factors that have been derived by the observation of a large group of patients, and then to apply them in a concept or in a score that try to predict which can be the response. This score has been firstly used in patients treated with the classical injectable, and as you see here, the curves separated quite well. The more high was the score, the more is the risk of a poor response to the treatment. We repeated such an exercise with other drugs, for fingolimod, for example, and we come up again with a very similar predictive factors, MRI activity, the amount of T2 lesion load, even to be older when we start the treatment is a predictive factor. And also in dimethyl fumarate, in another study in 500 patients again, we come up more or less with the same type of evidences. So the evidences can be more or less relevant, and usually the more powerful the drug, the less possible is to predict what may happen. Another very interesting lesson, I have to say. Another very interesting experiment has been trying to combine together the information on the impact of the drug with the information about the genetic organization in the patient. So what is called pharmacogenetic. Pharmacogenetic and pharmacogenomic may also give us some contribution. Unfortunately, all the results are not so exciting. However, very recently, at least 3 different studies, one from Barcelona, one for our own group, in collaboration with others, have really revealed that there is some possibility to look at such an impact. It's not a tremendous dimension of effect, but might be that in the future we can come up something better. I don't want to spend time to speak about this early predictivity because this has been for sure already quite largely discussed. But again, if you look, again, here mostly the predictivity is based, of course, on the persistence of MRI and clinical activity, to be very simple. And the last point is just the concept of predictivity when we have to start a treatment. And the lesson of natalizumab is really there. Pierre has clearly shown that we may predefine which is the risk of natalizumab, but a key question is this risk the same for everybody if they have the same level of antibody titer? The answer is no, because if we combine data coming from many different studies, it is quite clear that younger age, a high baseline EDSS, having a more active disease at the time the patient starts natalizumab treatment, define those are more risk. So if you have a patient with a very active disease and you are tempted to try to treat the patient with natalizumab, pay attention to that, because if the patient is antibody positive, when you will stop, the risk of rebound will be multiplied at least 3 or 4 times. So it's a bit, logic to think about that, but it's something that we must absolutely have in mind. Another key concept of that is changing our view in terms of treatment is the objective of the treatment. When we started in the 90s to treat patients with MS, the idea was try to reduce the frequency of the attack, and if you can, try also to take some benefits in terms of disability. But we knew that this effect in disability was very modest. Forget to produce any improvement in the patient. This was absolutely never evident with the injectable. Now we have completely changed. We are very ambitious. We have to be ambitious in life, and here the ambition means we have to pretend to maintain the patient free from clinical and MRI activity. All the other aspects, when you say, okay, it's not enough, I want to be also the patient free from MRI, brain atrophy, spinal cord atrophy, cognitive impairment, I have a bit of doubt that this is very logical, because if we believe that in the relapsing phase of the disease, what is really driving the negative consequences, then the effect on cognition, in fatigue, all these aspects are only a consequence of the fact that the patient continues to have inflammatory activity. So it is enough to demonstrate that we may have, with a given treatment, an impact on relapses and MRI activity to have a good type of result. Of course, the disability may dissociate from the effect on MRI and clinical. But if it happens, it's because the patient has entered the progressive phase. So we have to think in a completely different way, and I will spend a couple of considerations at the end. This is the evolution of the treatments, and I think that everybody will agree that what we really need to have is to have a bit clear ideas about which is the burden of a treatment and which is the potential advantage. And as a burden, we mean many things, not only the adverse effects, but also the tolerability problems, the convenience, the adherence, and many other aspects. So we can come up with something like this. Perhaps a good way is, if we think about the importance of the NIDA, is to try to look which is the impact of different drugs on the NIDA concept. Of course, this is a difficult exercise, because if you look at the comparison arm, the red columns, these are all patients in placebo. But as you know, these placebo columns, they go up and they go down. That means that when we compare across trials, we have a lot of differences in terms of population. So that's something that you have to take in our mind. So probably it's better to look at the ratio between the two, and not just at the absolute value. And then it is quite evident that these drugs have different powers. Of course, we have to pay attention to all the problems we have, old problems with the old drugs, new problems with the new drugs. No way to go in details about that. But again, this is a very important type of consideration. Of course, here I just mentioned only an example, and I don't want to go in details. But as a neurologist, we had to study more about infectious disease now, complications, because we've never been used to have to deal with such a problem. But that's something that is becoming extremely relevant. The new therapies has determined some new type of complication that we never thought before. So it's something that we have to take into consideration. Only one comment about what is the very recent evolution of treatments in terms of B cells. I think we should really pay attention to that. The European Charcot Foundation has just decided to dedicate the next meeting at the B cell, because it can be a bit overestimated, not only underestimated. It's very strange, because no one has sold before to the B cells in MS, then everybody is talking about B cells. Perhaps we need to digest a bit what is happening and try to have a bit more precise view about the B cells. For sure, these B cell anti-B cell therapies, and even, of course, other very strong therapies like alemtuzumab, for the first time have shown that we may also improve patients. Relapsing patients may improve in the early phase of treatment. And probably this is mostly because the so strong anti-inflammatory effect is able to eliminate all the inflammation that may enhance in some way the ability of patients to recover. It may take benefits from the brain plasticity, spinal cord plasticity, but it's quite clear. Initially, those of us who are involved in clinical trials thought that it could be an artifact. But now that we have seen more and more repeated such a phenomenon, it's clear that it's not an artifact. Some patients may really improve. And in the past, we used to say our patients, well, don't expect that with the treatment you can do better. It never happened. Let's at least try to have some, reduction on the speed of progression or on further attack. No, now we can say, you may have also some benefit in terms of improvement of the quality of life and the functions. And of course, I could not spend a couple of words about cladribine. It's not strange. This was the drug that has to be the first oral therapy, because all the steps of this drug have been completed in 2010, before fingolimod. And the drug was considered by regulatory activities with some rights, I have to say, having not a very good safety and efficacy profile. Then other drugs like, for example, alemtuzumab has been approved with the safety efficacy profile, definitely worse, no doubt about that. So it was then reasonable to reconsider also based on new information, also a drug like cladribine. And as you know, this is a drug that has quite a relevant effect on disability progression, And of course, the NIDA with this drug is very about 50%. So it is a very powerful drug. And also it's a drug that, very similarly to alemtuzumab, is working even after the discontinuation. And this is what clearly emerged here, because if you look at patients who have been treated with cladribine during the trial, during the Clarity trial, and then in the Clarity extension in the next 2 years, were shifted to placebo, it is clear that they continue to have a low relapse rate, and similar data are absolutely evident when we look at the MRI activity. That means that this type of drug has some ability to maintain a long-term effect. Another very important point that I want just to underline is that one of the reasons why the health authorities have reconsidered cladribine is also because there have been a lot of other data on safety coming from long-term studies. And more we need such an observational study. More and more we need that at the same time that we treat the patient, we try to benefit from what we see in the patient that we treat. It's a bidirectional interaction with the patient. That is really what we are trying to do. And more, and also health authorities are now asking us, do that. Do that in the appropriate way, do that in a very organized manner, come up with very clear registries, very informative registries. That could be something very important. If we do such an exercise, this is what we did, for example, in our center, we may demonstrate that if you have a NIDA condition, you take advantage in terms of disability, but also if you have a NIDA too. So if you are free from any attacks and MRI activity, you multiply by about 3 the possibility to remain free from any disability progression, which is in the long term. And similar data are emerged by other studies. So this interest in big databases is extremely important. There was a meeting a few months ago that has been promoted by EMA in order really to try to combine. And you see here very, very interesting data and very interesting results, because this type of very large data sets allow to have comparison across drugs. For example, here you see comparison of dimethyl fumarate with fingolimod, interferon, and so. And at the end, they may really help us to have a much better defined profile. I was very interested, for example, to see the results of the Swedish registry, where they had the opportunity to look at the impact of rituximab, and it was clear that the rituximab was much better than the other drugs in maintaining the effect. Of course, you may have a lot of biases, but that's absolutely interesting. So, trying to approach the end of my talk. So these are the tools that we have. These are the principles that we have to have in mind when we want to use this tool. Then what is now fundamental? Well, algorithms are invading our life. So everything you do, now we have to think about algorithms. And there are really a lot of criticism against algorithms because they are seen a bit like a constraint on the different type of possibility. Nevertheless, it's clear that we may use different strategies in treating our patients. We can take opposite view, just give first the importance of the safety, so try to treat with the very low risk drugs that unfortunately are also those that are also less effective, or vice versa. Try to use immediately the power you have in your hands and use the most active drugs. And here, I think the concept of induction has to be very clear. Induction is not only to use the most anti-inflammatory drugs. No, it's something different, because what we want to reach is the immune reset of the system. So in order to have such an effect, we need to destroy the pathogenetic T cell. And just to give an example, fingolimod, that has a very strong anti-inflammatory effect, has no effect in reducing the population of reactive T and B cells. So it is only way to postpone the disease, not to reorganize the immune system. And for this reason, we have to think quite clearly what you mean. And then we can come up with classical algorithms like this for escalation. Pierre has just mentioned before that neurophenomens have revealed and confirmed what we already emerged by other studies, that there's no reasons if a patient fails to interferon to go to GA or vice versa. because what really matters is how strong is the disease. So if you use the same level of power in contrasting the disease, you don't provide advantages. Yes, might be sometime a few patients may take a benefit, but as a general strategy, it's really not helpful. Much better if you use a real escalation. So if you fail to the level A of the pyramid, you have to go to the level B or C. And all the data here, I just showed this result coming from the group of Carlo Pozzilli study, where it was absolutely clear that it doesn't matter the type of outcome you want to use, patients who escalated compared to those who had the lateral shift did in much, much better in terms of data. So induction now is fundamental. And let me spend here a very important comment about how really Gilles has been instrumental. Because Gilles really spent a lot of energies. I remember when you came to Milan, trying to convince and to involve also Italy in this study, having the possibility to do the analysis of MRI data. And the study is still the only one with quite clear evidence that the induction strategy, so treating with a very intense immunosuppression, 6 months of mitoxantrone, provided a lot of advantages in terms of protection from disability progression compared to starting immediately with an injectable. I mean, this is the only study until now that has clearly determined in a very clean manner, and the advantage, as you can see, is a very, very large advantage. There are other indirect evidence that this is a good idea, and for me, the most important one is the results on the long-term observation of the effect of a very strong immunosuppression, and here we are talking about alemtuzumab, 7 years. And most of the patients had just a couple of years of treatment. About 1/3 have a third, some very few a fourth administration. All the others, they didn't. But then, when you look at the amount of accumulation of brain atrophy, you see that even in year 3, 4, 5, 6, 7, really the accumulation of brain atrophy is at the level, more or less, of the normal person, which is an incredible evidence, in my opinion, of the importance of this strategy. And the proportion of patients who enter in the secondary progressive phase is 3%. 3%. All epidemiological data have at least shown 4 or 5 times numbers compared to this over a 7-year period. And for this reason, probably, things are completely changed. I was shocked when I saw presented at Baveno, the Charcot meeting, this slide. This is telling you what happened in Sweden in terms of type of treatments. The green line, for those of you who are too far, describe the patients treated with rituximab. I was absolutely shocked because here the vast majority of patients in Sweden are treated with rituximab. Probably we should start to think about to be a bit more reactive. And of course, all the story of bone marrow is there. Here, just one note. Even with bone marrow, we have another very strong support to induction because the bone marrow now has patients that had the intervention more than 10 years ago, 15 years ago. And 3 different studies have analyzed the long-term effect of bone marrow transplantation. And the proportion from 60 to 75% of patients treated with bone marrow, after about 10 years, they are still without any evidence of disability progression. And usually, we don't treat quiet patients. We treat very aggressive. Even if you have this bias in the selection, the more aggressive cases, the results are extremely important. Having said that, this is my personal view about what to do. So what to do is to treat based on the type of the profile of the patient. And then you may have patients who are with a very negative profile, and in these cases, please do your best and do an aggressive therapy. This is 70% in our population. This is a study based on 3,000 patients. Then you have, on the opposite, a population of patients that seems to be with not very negative prognostic factors. they seem to have a very, let's say, not negative future. In these cases, we can still consider to have a treatment, provided then you have a very narrow monitoring that you allow you to select those who have been in a very bad, wrong initial classification. Unfortunately, there is a last body that is about half of the patients, where it is still difficult to say what to do, because the prognostic factors are not so good, but even not so bad. So in this category, I think, it is the future that will tell us what to do. My personal view is to move this category to the category of induction, but I can accept also the other views. So to close almost the end, my message is that we should be very ambitious. We should have the ambition to take our patient free from the disease and do our best to be very aggressive when necessary. Not to use NIDA in an obsessive way, but to use NIDA in a clever way. That's possible. The last 1-3 minutes, only to say something about progressive MS, also because I'm deeply committed to this. Now it's clear to everybody that progressive MS is something different pathophysiologically than relapse-remitting MS, and most of the problems in progressive MS are due to a compartmentalized inflammation. However, I'm absolutely convinced that the vast component of what happened in the progressive phase is determined by what happened in the relapsing phase. So if someone asks me which is the best way to treat progressive MS, my response is treat well the relapsing phase of the disease. That's really my point. But we have already patients in the progressive phase, so we do something here. And we know that for the first time we have 2 active treatments, siponimod and ocrelizumab, one in secondary, ocrelizumab in primary progressive MS. And again, what is very curious is that in this study, what was really evident was that those patients who did better are those, again, who had a residual of inflammatory activity, a residual of relapsing phase. That's true even for siponimod, it's true for oratorio. So here, my view is, but I discussed with Gilles exactly about this point, we come up with the same exactly definition. We have also a window of opportunity also for primary progressive MS and secondary progressive MS. The window of opportunity is in the early phase of the primary and secondary progressive, when you still have the target for our anti-inflammatory activity. It could be that in the future, when we start to have real drugs that have some effect independent of inflammation, biotin, particularly here in France, is so interesting. You see the data. But I think, unfortunately, until now, some type of treatment that is really able to modify the pure progression is quite far and is still not available. Last point. When we have to treat a patient with MS today is becoming extremely complicated. To protect the patient for negative impacts of the drug is extremely complicated. It's time to call for an action so that all patients are treated in the appropriate units that we have proposed in Charcot to call a care MS unit, very similar to what patients has in a stroke. I think this could be really one of the most, for the next 25 years, what we have to do. Thank you so much for your attention.
Thank you, Professor Comi.